Thank you, Sarah. I appreciate it so much. And welcome everyone to the webinar. We're really excited that you all are here and that today's webinar is such a pertinent topic to today. And so for those of you who are not familiar with the Quality Assurance Center, we are jointly funded by the Office of Child Care, the Office of Head Start, and the Health Resources and Service Administration's Maternal and Child Health Bureau. The National Center on Early Childhood Quality Assurance supports state and community leaders and their partners in the planning and implementation of rigorous approaches to quality in early care and education settings for children from birth to school age. This webinar is co-facilitated by the American Academy of Pediatrics. Today we are excited to have two of our project officers here to welcome all of you. From the Maternal and Child Health Bureau, Dr. Leeser. Thank you for being here, Dr. Leeser.
Thank you so much, Jean. I'd like to extend a warm welcome from HRSA's Maternal and Child Health Bureau, where our vision is of an America where all mothers, children, and families are thriving and reach their potential. And our goals are to assure access to high quality and equitable health services to optimize health and well-being for maternal and child health populations, achieve health equity, strengthen public health capacity and workforce, and maximize impact through leadership, partnership, and stewardship. It is particularly exciting to be with you today at what is a moment of such complex challenge and also unprecedented opportunity to build back better. I am so thankful for our partnership with ACF and the National Center of Early Childhood Quality Assurance. I am so grateful to all of you for joining with us today. It is exciting to be intentional about creating opportunities in which we can come together across sectors to focus on our common goals. The only way we can accelerate progress and move upstream to build well-being, achieve health equity, and avoid predictable poor outcomes is by working together to improve the health and well-being of our youngest children and families. And this can only be achieved in the context of a comprehensive early childhood system, which includes strong and coordinated systems of developmental promotion, early detection, referral, and linkage, which each one of you have an important and unique role to play within. I will now pass it on to Letha. Thanks so much.
Thank you, Dina. Good afternoon. I'd like to welcome everyone to today's webinar on behalf of the Office of Child Care and extend a special thanks to our partners supporting this event, including the Maternal Child Health Bureau, the Office of Head Start, and the Office of Child Care's National Center on Early Childhood Quality Assurance and its staff, and to the distinguished experts on the panel that will share information and draw much needed attention to this most important issue. With states reopening, many parents returning back to work, and families' need for early care and education program services increasing, it's an opportune time to raise awareness across the country on the importance of early detection, screening, and referrals as a critical component of preventive care. Studies demonstrate that alignment and coordination of critically needed interventions make a difference, and the unanticipated and devastating effects of COVID on the overall mental health and well-being of children and families reinforce the critical need for more intentional efforts and supports to better align and coordinate early detection and screening services within the early care and education community. Our renewed focus on addressing the gaps and wide variations of early detection, screening, and referrals across states, territories, and tribes to improve consistency, access, and overall quality of services grounds our work together as we strive to improve children's healthy development, wellness, school readiness, and learning across all early care and education settings and programs. Thank you, and I'll pass it back off to Jean.
Thank you so much, Letha and Dina, for that warm welcome, and we're so glad that you could be here with us today. So Florence Rivera and I will be facilitating today's webinar. As Sarah shared, all of the speaker bios are available in the handout file if you would like more information. And I do see some of you are having a hard time seeing the slides. And if that is the case, you may need to exit out and come back in, and you should see everything. As a result of today's webinar, we hope you will recognize that the early childhood community has a critical opportunity to partner to build a stronger system of support for children and families to access screenings at multiple entry points in childcare settings, home visiting, health providers, community-based health centers, Head Start, Early Head Start, or early intervention services. The objectives of today's webinar are to recognize the impact of the pandemic in reducing access to developmental screenings and the increasing need for these screenings, understand the importance of increasing access to developmental screenings, resources, and services for all children, discuss the need to be intentional in selecting culturally sensitive developmental screening tools, and understand how adult behavior may influence outcomes of screenings, and examine opportunities to collaborate with health and other early childhood system partners to increase access to developmental screenings for all children. As many as 1 in 4 children through the age of 5 are at risk for a developmental delay or disability. If developmental concerns are caught early, we can help ensure that children receive the support they need and that they are linked to the appropriate services. To help ground us in our discussion today, let's review terminology regarding developmental screening. Caring for Our Children National Health and Safety Performance Standards defines developmental screening as the use of standardized tools to identify a child at risk of developmental delay or disorder. Typically, you will hear the word disability versus disorder, since disorder is more of a medical term, while disability is the legal term that appears in the Individuals with Disabilities Act, IDEA, and Section 504 of the Rehabilitation Act. The Early Childhood Learning and Knowledge Center further broadens that definition to recognize that these are done in partnership with parents. Screening is part of a larger process professionals use to learn about children's health and development. Additional terminology includes monitoring and surveillance. So what is the difference between developmental monitoring and developmental surveillance? Developmental monitoring refers to observing how a child grows and changes over time and whether the child meets typical developmental milestones. Parents, grandparents, early childhood providers, and other caregivers participate in developmental monitoring as they document a child's day and achievements. Developmental surveillance is the process through which children who have a developmental delay or are at risk for a developmental delay are identified. This occurs at well-child visits with a health provider and consists of obtaining parental concerns, identifying risk factors, monitoring development, and collaborating with other providers and professionals. A screening identifies children who are developing on schedule, children who might benefit from practice or support in specific areas, and children at risk for developmental delays who should be referred for further evaluation. Additional types of screenings include the ones listed on your slide, and those are typical ones that parents may be more informed about and recognize. Screenings can answer that question of, does the child need an in-depth assessment? So why this? Why now? As a result of the pandemic, children have demonstrated increased social and emotional needs. Along with disruptions in their routines and caregiving, children may have experienced a regression in skills or potential delays. Parents were dealing with multiple stressors, including illness, job loss, finances, working from home, and supervising online learning for their children. The pandemic resulted in a decrease in the number of children who received screening services and potentially increased the need for these same services. When comparing data from March through May of 2019 to March through May of 2020, the data showed 44% fewer child screening services were done during that time frame. If we think back to the statistic that 1 in 4 children are at risk for a developmental delay or disability, that means at least 1.1 million children may have needs that went unidentified during that time. While child health services utilization has now begun to increase, use of these essential child health services have not yet returned to pre-pandemic levels. And as we work to advance equity to provide everyone with the opportunity to reach their full potential, this includes recognition of disparities that exist in the developmental screening process. Early intervention is the key to setting children with delays and disabilities on a path to long-term success. Yet children of color face barriers to accessing these services. According to the Impact of Race on Participation in Part C Early Intervention Services, Black children were 5 times less likely to receive early intervention services than white children. Black children with developmental delays are 44% less likely to be identified as such and receive the services they need. Latino children with developmental delays are 78% less likely to be identified as such and receive services. In an early intervention report from the Education Trust in May of 2021, shows that children of color often have less access to programs in which specialists are trained to use screening tools, such as high-quality healthcare and early childhood education programs, resulting in fewer screening opportunities. Children of color living in low-income neighborhoods are less likely to receive evaluations due to a limited access to developmental screenings, and when they are screened and referred for evaluation, they are less likely to be tested. This could be due in part to a limited supply of evaluators in their area, though much more research is required to determine all of the contributing factors. Children of color who are eligible for services are also less likely to receive them and more likely to face challenges while receiving them. This is due to a variety of factors, including insufficient outreach and a lack of culturally competent services. Another critical component in equity is the cultural and linguistic competency of the evaluation process, including assessment tools. Screening tools may include language that a child is unfamiliar with. Content bias can occur because an individual may perform differently across racial or ethnic and cultural groups due to different parent beliefs, child rearing practices, or customs. It is also possible that raters interpret the behavior of a child of a different race or ethnicity or cultural group, resulting in an unconscious bias. There are several strategies that can be used to increase access in the health and early childhood system, which includes ongoing professional development, family engagement strategies, aggregated data collection, the development of culturally and linguistically competent assessment tools and practices, and partnering across the early childhood system. As you think about the developmental screening in your jurisdiction, where are the access points for children and families for these screenings? Are there intentional connections being made between these access points, or is this a place where you could build back better and build stronger relationships to support children and families? Sarah is going to bring over a poll, and we'd like to know, How many of you are currently partnering with other early childhood entities to provide screenings for young children? And I see in the chat, there's a question about asking for us to share the data presented today in a fact sheet or other means. Absolutely, we will work to make sure that you have all of the data that is being presented in the notes. So it looks like 72% say that they are, 73% say that they are already partnering, and that is so exciting to see. That is just so exciting. And I really appreciate you taking the time to fill in the poll. And Toya, you asked about the slide information, and just in case folks have missed it, yes, the slide deck will be sent out after the webinar. We will be sending you a follow-up email with the slides as well as the recording. All right, thank you so much, Sarah, for pulling that over for us. As you partner with stakeholders that provide access points for children and families, it is important to engage Part C and Part B providers, as well as family resource centers that can connect children and families to resources based on their needs. As with most services during the pandemic, resource providers had to adjust the delivery of their services. And now is a time to look at ways to increase access for all families. Engaging families is important, and explaining that these screenings are a normal process for children, just like a hearing or vision screening, helps to inform families on what the process is and takes out the mystery of screening and increases their active involvement. Before conducting a screening, parental consent is required, as it is for sharing the results with other early childhood systems partners. One jurisdiction uses the Ages and Stages questionnaire enterprise system for screening completion and gives free access to early education and child care programs statewide. They have a Help Me Grow program, which you're going to hear more about today. And their Help Me Grow staff educate healthcare and early childhood professionals about screening children for developmental and social and emotional concerns and help link families to community services and supports. This requires parental permissions on file in order to share the screening results across the system. I hope that in this first section of the webinar, you have heard the compelling reasons to enhance developmental screening opportunities for all children. And you have also thought about possible partners in making your system stronger. In this next section, we will focus on models of screening efforts and supports available to assist you and your jurisdiction in their efforts. Parents and early care providers can work together to provide the responsive interactions and consistent environments that nurture the development of young children. Practitioners can screen and identify children early, promote family strengths, and refer to services before risks progress. States and communities can use surveillance data to drive action around early childhood investments. Partners with public health can use data-informed approaches to prevent health disparities by facilitating service linkages across health, social, and educational systems. Timely referral and better integrated services might help children at low or moderate risk reach their full potential by returning to healthy developmental trajectories. Florence, we're going to turn this over to you, and will you please say good afternoon to everyone, and will you please walk us through our panelist presentations?
Wonderful. Thank you so much, Jean. And thank you for that wonderful presentation. As she mentioned earlier, I'm Florence Rivera. I am with the American Academy of Pediatrics, and we are so pleased to be able to co-sponsor at least a portion of this event, and to let me introduce our next panel of amazing speakers. But before I do that, I just want to share a couple of opportunities. sorry, Sarah, I'm having a hard time moving it to the next one. There we go. That I want to highlight for us. We want to partner with you. If you're not familiar with who we are, the American Academy of Pediatrics is a member society of 67,000 pediatricians and pediatric healthcare providers. We are the conduit to local pediatricians. We have state chapters and several states that have more than one chapter. We also have chapters in Canada, in case you're interested for that as well. And then we have 65 early childhood chapter champions who are primed to work with early care providers, early interventions, home visitors, etc., when thinking about the needs in early childhood for children and their families. So I don't want to take up too much time. I know that Jean has pulled together a wonderful resource of everyone's bio, and that includes my information on there, and would love to hear from all of you about how I can facilitate or the Academy can facilitate connections. So with that said, I'm going to turn it over to people who are much more interesting than I am and introduce our next speaker, which is Julia Abercrombie from Learn the Signs, Act Early. And I highly recommend everyone hear a little bit, read a little bit more of Julie's background on our bio list. All right, Julie, I'll take it away, please.
So sorry, can you hear me now? I'm having internet issues, unfortunately. Hopefully
we can see you and hear you.
Okay, great, sorry. Dropped right as I was being introduced, so that's, that's a bonus for me. It's on my bingo card. So thank you so much for having me today. So we've heard a lot about the importance of screening, and there are some best practices in screening that we've mentioned, as well as engaging families in the purpose of screening and gathering feedback from families about screenings. And that is really to make it a more meaningful process. And so we think of the first step really in a comprehensive and successful screening program is to first consider what you can do to help facilitate developmental monitoring and this ongoing tracking of development. So step one, we feel, is really sharing information with all families about child development and introducing the concept of what developmental milestones are, and that there are these things that children do by a given age that are called milestones that are important for all families to be aware of and to track. And so that's what we provide resources to do that at CDC's Learn the Signs Act Early program. So I've highlighted here a few resources that are particularly helpful for early care and education providers. So since we're a program of the Centers for Disease Control and Prevention, everything that we offer is free. And that includes the tools for monitoring milestones to help parents become more practiced at observing milestones in their children. And they also do include information about what developmental and autism screenings are, why those are important, and even some of our resources, like the app, which I'll mention in a moment, includes prompts for reminding parents about screenings that are recommended at given ages per the American Academy of Pediatrics schedule. And then we also have a training that I wanted to highlight that is specifically for early childhood educators. That's the Watch Me Celebrating Milestones and Sharing Concerns online training. And it covers ways to talk with families about development, both when there are no developmental concerns and a child is reaching all of their milestones, as well as when there are developmental concerns and you want to raise those with the family and encourage acting early on those concerns. Additionally, we have at least one Act Early ambassador in every state and in DC and in some territories now. And these ambassadors are individuals who represent our program, and they help to connect programs to the resources that we have and fill them in where they are needed most. And we know that many of them are already partnering with early childhood programs and many with early childhood education programs. And in fact, you'll hear from one of our ambassadors, Dr. Alderman, who's our ambassador to Oregon, among her many to fund ACT Early Response to COVID state teams through a cooperative agreement with the Association of University Centers for Disabilities. And you can follow the link on this slide here, and I think it'll be in the notes as well, to see where those 43 teams are located, who's leading them, and get a brief description of what their activities are. But these teams are trying to address the challenges that communities have faced because of COVID-19 that are related to monitoring, screening, referral, and linkage to services. Let's see if I try to go to the next slide. There we go. I wanted to highlight a few of the resources for families. So again, we have milestone checklists for children 2 months to 5 years of age. We have those in print form, and we have them digitally in the Milestone Tracker app. And we think it's very important to provide resources in a variety of formats, because we know that families are very diverse and need information in different formats and in different ways. And so we try to tailor to the many ways that families like to receive information. But the Milestone Tracker app has been really heavily used during this time when digital services have been some of the only options for families. And it is a pretty comprehensive resource. And as I mentioned before, it will send pop-up notes to remind families when screenings are due and explain what those are and provide links to where they can find more information. So it's a great tool to introduce and reinforce some of the messaging that you might be sharing with families about screening in your program. Please visit the link here for more information about the resources. There's also children's books, a photo and video library of all the milestones to help to avoid some of the pitfalls with readability and help with comprehension of what we mean by some of the milestones, so that they can watch a video of a child demonstrating what the milestone is. So please check them out. Everything is in English and Spanish, and we have a variety of other languages available as well. And Florence, I think I'm turning it back over to you. Thank you.
Absolutely. So thank you so much, Julia, for that great presentation. And I saw in the chat box that we had folks who were very familiar with using the app with their grandchildren. So thank you for sharing that. And it sounds like some wonderful resources. Next, I'm going to turn it over. It's my pleasure to turn it over, actually, to Dr. Paul Dworkin with Help Me Grow. And I had the pleasure of hearing a little bit about his work last year at our national conference. And so I know he's going to give a fantastic overview of some of his work. So Dr. Dworkin, please take us away.
Thank you so much, Florence. I'm so pleased and really so honored to be with all of you for a number of reasons. Let me just mention three. First of all, for those of us who are engaged in the process of strengthening families to promote children's optimal health, development, and well-being, we know that all of you in the audience are those with whom we must partner to achieve these goals. So it's just great to be with you. Secondly, I love the title of this webinar. We have spent decades trying to figure out the terminology that best characterizes what we are trying to do in strengthening child's health services, to promote children's optimal health development and well-being, in evolving, disseminating, and implementing the Help Me Grow model that you will hear more about in just a few minutes. And the terminology that we use is a comprehensive, integrated approach to developmental promotion, early detection, referral, and linkage. So to see this terminology used as the header for this webinar is so validating. Thank you. And third, I so appreciated Jean's comments on specifically placing screening within the context of surveillance and screening, and placing surveillance and screening within the broader context of early detection. And I'll say more about that in just a moment. So thank you for the privilege of being with you. Let me begin just making a couple of additional comments regarding the process of early detection, specifically the process of developmental surveillance and screening, which has been the officially recommended best practice approach to early detection endorsed by the American Academy of Pediatrics. The AAP originally published a policy statement on surveillance and screening in 2006, and most recently reinforced the principles of that policy statement in a practice guideline published in December of 2019. As Sions suggested, surveillance and screening is an integrated process. It is not surveillance or screening, and it is never surveillance versus screening. These activities are meant to work together in a comprehensive, integrated way. Surveillance is the longitudinal component, a flexible, longitudinal, continuous process in which skilled practitioners perform observations during child health encounters within the early care and education setting, within the family support settings such as home visitors. And Jean has already articulated the components of surveillance. Let me particularly emphasize two. Number one, the paramount importance of eliciting and attending to parents' opinions and concerns. Parents' opinions and concerns are extremely important indicators of increased developmental risk. My personal opinion is the single most important activity of early detection is consistently eliciting and attending to parents' opinions and concerns. Another key element is, particularly when concerns arise, sharing opinions with other professionals. And yet we within the child's health setting are challenged to reach out and connect with early care and education providers, with family support providers like home visitors, even when we have concerns. And I think the same is true for providers in those other sectors. And yet sharing opinions is an incredibly powerful approach to identifying children who are at increased risk for adverse developmental and behavioral outcomes. So it's surveillance and screening. There is a critical element to early detection that we must be mindful of, and this was clearly articulated by our developmental and behavioral pediatrics colleague, Ellen Perrin, back in the 1990s. We long recognized that detection without action, that is, detection without referral or intervention, is certainly ineffective, and yet Ellen pointed out that it may well be judged unethical. So we recognize that we must be particularly cognizant of the critical importance of ensuring that early detection of children at increased risk for adverse developmental and behavioral outcomes and their families be appropriately linked to culturally appropriate, geographically appropriate, community-based programs and services, especially for those children who may not have the degree of delay that would enable their eligibility for Part C, Part B, or Title V children with special health care needs support. So with these issues in mind, back in the 1990s, the mid-1990s, we evolved a comprehensive integrated model to attempt to advance early detection, developmental promotion, early detection, referral, and linkage of vulnerable at-risk children and their families to community-based programs and services. And as was true for the original pilot study of Help Me Grow in Hartford in 1997, and equally true for Help Me Grow today as it is disseminated across the nation, there are 4 core components of the model: family and community outreach, child health provider outreach, a central access point, which is really the heart of Help Me Grow, and data collection and analysis. And let me offer just a few comments on each of these 4 core components. As I mentioned, the centralized access point is really the heart of Help Me Grow. Across all of our Help Me Grow affiliates, it's a specialized child development line that is staffed by care coordinators or may be accessed in many instances online by families. It enables linkage and follow-up. It ensures that families and their children are linked to geographically appropriate, culturally appropriate, community-based programs and services, and it overcomes barriers in ensuring that linkage occurs. And in fact, the experience in our affiliates across the country is an 80 to 85% linkage rate of children and families to community-based programs and services. The centralized access point also does the heavy lift, the incredibly important lift of researching resources and ensuring the maintenance of a real-time directory that is up to date with regard to the programs and their capacities to minimize frustration in the referral and linkage process. Family and community outreach is extremely important. Engaging families where they are, whether during child health supervision visits in the child care setting, at home with home visitors and other community-based sites, engaging families to help them appreciate the critical importance of their sharing their opinions and concerns, and also ensuring that they are aware of the capacity of the Help Me Grow model to link them to desired community-based programs and services. Community outreach to engage all of the community-based programs and services that are available to families and their children, and also to ensure that they are mindful of the Help Me Grow process, the process by which children and families can be linked to them. Child health provider outreach to ensure that child health providers are trained in effective developmental surveillance and screening, and also they are aware of the capacity of the model to link their children and families to community-based programs and services. And then fourth, but certainly not least, data collection and analysis. We know in every community there are gaps. In every community there are capacity issues. We need data to inform our advocacy. In addition, we know that in order to sustain a comprehensive integrated model of developmental promotion, early detection, referral, and linkage, we must have the data that speaks to the effectiveness of the model. So all 4 core components are critically important and act together. So the pilot study in Hartford from 1997 to 2002 resulted in Connecticut, the state of Connecticut, disseminating the Help Me Grow model across the state between 2002 and 2004. Today, as we speak, we in Hartford at Connecticut Children's house the Help Me Grow National Center, which supports 32 states and 110 Help Me Grow systems across the country. So let me spend a couple of minutes focusing on Help Me Grow's engagement with the early care and education sector. And we've so appreciated the extent to which Help Me Grow has become a vehicle for early childhood comprehensive system building. Our interfaces with all sectors are critically important: child health, early care and education, family support, and others. With respect to the early care and education sector, a few years ago, in 2017, we, with support from the W.K. Kellogg Foundation, in the Help Me Grow National Center, organized what we called an Innovation Challenge, in which we solicited promising innovations from our affiliates across the network. Many of the leading innovations focused on system building, and more specifically focused on how to strengthen developmental promotion, early detection, referral, and linkage through engaging the early learning sector. And we were so impressed by these innovations that we opted to organize a structured multi-site community of practice, which ran from 2019 to 2020. This was led by two of our affiliates, Help Me Grow Orange County and Help Me Grow Vermont, and 9 Help Me Grow affiliates participated in this community of practice. We recognized very quickly that our ability to interface optimally with early care and education, with child care programs, must take advantage of the Quality Rating Improvement System, QRIS, which for those of you who may be unfamiliar, is a formal method to assess, improve, and communicate the level of quality in early care and education settings. So we partnered with the BUILD initiative and their QRIS National Learning Network to provide technical assistance to our affiliates who were looking to strengthen their relationships with early care and education through the quality improvement strategies of QRIS. This was not a heavy lift. In fact, it was viewed as highly synergistic because the QRIS methodology had already incorporated the importance of developmental screening. Here are the SMART goals, which our 9 participating affiliates embraced in this community of practice, increasing the number of early learning programs conducting developmental screenings and subsequent referrals to the Help Me Grow centralized access point. Utilizing technology platform, like for example, the ASQ Online, to increase family engagement and provider capacity to conduct developmental screening. Learn the Signs Act early. Embedding developmental screening and linkage to services into QRIS standards. So not having developmental screening stand alone as a standard, but rather integrating it within developmental promotion, early detection, referral, and linkage. And supporting early learning professionals through increased professional development. There were so many positive outcomes from this work. I'm going to share just 3 with you very briefly. There was a notable increase in developmental screenings, beginning at approximately 450 or an average of 100 per Help Me Grow community, and increasing to 1,200, an average of 300 screenings per Help Me Grow community, a tripling in screening rates. The number of referrals from early learning settings to the Help Me Grow centralized access point increased from a baseline of 150, again, a 3-fold increase to 450 over the project period. And then 5 affiliates reported that they collectively conducted 82 outreach activities and over 200 professional development activities. Extremely impressive results for an initiative of just 1 year. And let me give you an example of some of the impacts in our various affiliates. I'm just going to read these for you. Alaska is a tight-knit state, so organizations often work closely together, but sometimes it can take a catalyst to spark the next phase of a partnership. Help Me Grow Alaska and the QRIS system, Learn and Grow, have always been closely linked, but as part of this community of practice, regular meetings started taking place that began a more structured collaboration. And there were a number of benefits that ensued from this collaboration. Help Me Grow Alameda County, California. Through this project, we deepened our engagement and relationships with our early learning partners, learned about their needs of support from our phone line staff, and have begun a thoughtful process for changing our feedback protocols for referrals from early learning. Help Me Grow Orange County. They had already observed that the QRIS strategies were extremely successful for center-based programs, but were not effective with family child care. Through this process, they were able to refine and adapt the QRIS system such that screening and linkage to needed services also occurred to a very high degree among family child health providers. And then I don't want to leave you with the impression that QRIS has only been helpful within Help Me Grow affiliates. There also are examples of other states that are not yet part of our Help Me Grow affiliate network. New Mexico, in which developmental screening and vision, oral, and hearing screenings were amplified through QRIS. Rhode Island, in which surveillance and screening was embedded within their child assessment process through QRIS. Nevada, in which the use of a short screening tool was again brought to scale and impact to identify children with delays. There were all sorts of lessons learned from Help Me Grow and our collaboration with QRIS. I'm not going to go through this table. I would invite you to review it at your leisure. The themes included the value of the model as a resource to providing information about child development and resources, the benefit of the model in providing professional development opportunities to early learning providers, and the importance of a robust QRIS approach to improve quality within the learning setting. Really profoundly important implications. So let me end with just two other thoughts. One is the importance of early childhood comprehensive system building, the utility of a comprehensive integrated approach to developmental promotion, early detection, referral, and linkage in the context of the pandemic. And all of our speakers have acknowledged the pandemic. How can we not? So what we found among our affiliates during the pandemic has been a striking increase in calls to the Help Me Grow centralized access point. A majority of our affiliates noted a significant increase in calls in response to the impact of COVID-19, and our central access points were called upon in unprecedented numbers to connect families to resources, to address families' basic needs. We also found that our model was incredibly efficacious in being able to very quickly bring supports to families. Through a very generous grant from one of our foundations who support our work, we were able to engage 10 of our affiliates to very rapidly distribute nearly 3 million resources to families, over 30,000 unique interactions with families, and as you could see, very, very high numbers of diapers, wipes, formula, and other basic needs distributed to families. Again, the importance of a comprehensive, integrated approach and early childhood comprehensive system building. Finally, let me just point out to you that the approaches that we've described for early care and education within the early learning sector apply equally well across all sectors that are so critically important to early childhood comprehensive system building. I had the privilege of participating in the National Home Visiting Collaborative, the McVie Home Visiting Coin. We focused on strengthening home visiting programs capacity in developmental promotion, early detection, referral, and linkage. And again, the results really speak for themselves. The percent of children with an identified developmental concern who received support increased from a baseline of 70% to 82%. Parents were asked about developmental concerns at 95% of visits, and 90% of children were screened every 6 months. So, on the basis of this work and all of our interrelated work on comprehensive early childhood system building and promoting children's optimal health development and well-being through developmental promotion, early detection, referral, and linkage, I will end by sharing with you 7 model elements that deserve consideration in all of your work. Number 1, ensuring equity through targeted universalism. Help Me Grow is a universal approach, but we facilitate access for those who need it the most. Connecting to families through outreach efforts. Again, I talked about engaging families where they are, maintaining a comprehensive, up-to-date resource inventory, incredibly important and challenging work, linking families to community-based services, providing ongoing support to families, partnering with physicians through systematic feedback loops. When families are connected to programs and services and child health providers know that, the medical home can continue to coordinate care. And finally, again, last but not least, leveraging technology to sustain support for families. We have so many examples of this. So my hope is by doing a deeper dive into the early learning sector and calling out the critical importance of early childhood comprehensive system building, these critical elements can inform the work that you are doing, regardless of the specific sector within which you are engaged. Thank you.
Thank you. And next up, we have Dr. Marian Earls.
Hello, thank you. You can hear me, I hope. I had a little trouble getting connected earlier. So I'm going to talk to you a little bit about our efforts in my state around screening, but beyond that, and how we can partner with primary care, with our early childhood education partners and many other folks working with young children. So I'm hoping I can advance these slides. Can I? There we go. So in North Carolina, we've had this ABCD program, the Assuring Better Child Health and Development Program, since 2000. And initially, this was funded by the Commonwealth Fund. Many other states were involved with this project as well. But it became integrated into the work that we were doing in Community Care of North Carolina, which was actually the delivery arm of Medicaid. We were statewide, and we integrated it into the work that we did with pediatrics in that program. And now it has transitioned in our recognition around social emotional health and social emotional development into an initiative funded by Duke Endowment called Early Well. But from the outset, we convened this very large cross-sector state advisory group, and I'll give you a little more detail about the content of that advisory group. We were focused on collective impact. We met quarterly for 19 years and now continue to meet as our Early Well advisory group. And we transitioned to that early well group at the beginning of 2020. So let's go to the next slide. So just a little bit about this project. It started as a developmental screening project, like so many, but expanded to include autism screening and postpartum depression screening in the early 2000s. But it's now expanding to include social, emotional, and social determinants of health screening in primary care as a two-generational approach to prevent and ameliorate toxic stress, but also to promote positive childhood experiences and family protective factors. So just a little bit, you can see this is a fairly busy slide about our state advisory group. And we had a quality improvement group as well, which I won't really get into discussing today. But that group was active since 2001. And you can see that list there of the members of the state advisory group. I just want to point out that in order to do this work and do it well, as Paul was just talking about, that interconnectedness, knowing community resources, being able to connect families well, to connect for primary care clinicians to understand who's in the community, how do we do this work, how do we center our work on children and families. We really had to include in this cross-sector group lots of folks. That included primary care, it included our friends at the public health, at the state public health, early childhood settings, including Head Start and other childcare settings, preschools, the preschool exceptional children's services through Part B, our infant and early childhood mental health folks. And you can see there are lots of other folks, our CCR&R, folks that were doing Reach Out and Read in primary care, our Autism Alliance in the state. So many folks, including pediatricians and family medicine physicians are in our Medicaid program. A subset of that group became our infant and early childhood mental health team. And that group right now, you can see that we were able to integrate the diagnostic classification 0 to 5 into Medicaid policy and have trained professionals of various sorts, teachers, psychologists on the DC 0 to 5. But we're now working to expand infant and early childhood mental health consultation in our state and in many others that is somewhat limited to being available to teachers in Head Start, but we're working on expanding that consultation to be available to other preschool and childcare settings, to Part B and Part C professionals who are working with families and children, to care managers and home visitors, to our child welfare folks, and also for our primary care clinicians. So this is a really fascinating cross-sector effort, but again, recognizing that we all need to be in that together. So the advisory group recognized early on that the essential part, that standardized communication among all of us was an essential part of systems serving young children and families. So you see that list there of folks that we really wanted to be sure that we had a standardized, routine way that we communicated with each other, with families for the care of children. And you can see that included our Title V program, where we have care coordination for children, which is a service for children who are at risk, age 0 to 5. There's no eligibility requirement aside from a referral from a variety of places in the community and the state, in our infant and early childhood mental health folks. What we realized there was not then, and there really isn't now, an integrated data system that facilitates this kind of communication. But our goal was to not let the perfect be the enemy of the good. And we've worked diligently on developing our standardized communication processes as we move towards a way that we can share data more electronically. We realized that this communication was also essential for being able to do warm handoffs. That is our priority, that when we're helping families with services, that we're able to make a warm handoff for that referral. Much more successful than saying to families, we think you can go to this agency, or we think you can go here, or here's a phone number to contact. And so it was very important for us to set up these communication systems. So this next slide is a pretty busy one as well. We made an attempt to take a look at all of the folks that we wanted to have this bidirectional communication. And I apologize for the fact that the child and family are at the top instead of in the middle of all of this. But when we put them in the middle, we look like we were tying them up. So, but the intent of this is that the child and that the family is at the center of this communication as well. So you can see I think you may have to click a few times on that slide to get all of the bidirectional arrows in. I thought I took that functionality out, but I evidently didn't. So just keep going because it is a little more dramatic to be able to see all of those pathways. I think there you've got it. So you can see that we included our obstetrical prenatal folks in this work. So that included obstetricians and OB care managers. And then you see the box for PCC as the primary care clinician. Then we have home visiting to that right side, and then early childhood education, which obviously encompasses lots of folks. We also had our intensive care nurseries who were referring children. That orange box is that CC4C, those care coordinators who are nurses. But you can just see the complexity of the need for this communication. And what we really needed to do, out of respect for families, is to not have families have to figure out this mess. We needed to be doing a better job of making sure that communication was facilitated rather than having our families have to do that. In that row at the bottom of the variety of services, infant mental health, of course, CDSA is our Part C program. We have Part B there, and we have our family support network. So they're also part of our ongoing advisory group, the various family advocacy organizations. So enough about our landscape map. Let's go a little bit to our results, which is our next slide. So, this cross-sector work is very, very intense, and we all don't know each other very well, right? So early childhood folks don't necessarily feel like they have facilitated communication with people in health in primary care, and vice versa. So this was a challenge for us with this group to begin to help familiarize ourselves with each other, our lingo, the way that we do our work, the processes and rules and regulations that people had to work with. So what we were able to do is come up with statewide forms. We developed consensus around these for referral if there was a screen that showed concern. And we developed a two-way release of information that everyone could agree with. And also a feedback form to be used by our Part C and Part B folks when they were giving feedback to the primary care clinician about what was going to happen for these children. Those were huge, very simple when you look at them when they're all done, but it was a long time for people to develop that consensus, and with all those state agencies, et cetera. The consensus on the two-way release form was particularly important to meet regulations around HIPAA and FERPA. And what we realized is if we had a really good two-way release of information that we engaged families in developing and in using, then the family was always going to be the center of that care team. And they're going to be central for that whole process of communication and referral. So it served many purposes, really. It took care of everybody's concern about talking to each other and exchanging information, but it also required us to include families at the center. We developed referral guidance for the primary care clinicians, both pediatricians and family medicine folks, in terms of how to make those referrals, how to make contact with your Head Start program, how to contact your local Part C folks, all of those sorts of things. And how do you do that? And what information do people need in order to assist with that referral? Now, we had some great outcomes. We have had great outcomes. You can see there that in our Medicaid program, which is almost 50% of the children in the state are eligible for Medicaid at that young age, developmental screening and screening for autism in early years is at a 94% rate in Medicaid, probably one of the highest in the country actually right now. And maternal depression or perinatal depression screening also at around the 90% mark happening in primary care, so that when parents come with their infants for those early infant visits, there is screening for perinatal depression, because how much we understand that that can impact that family relationship, the relationship with that infant, and also that infant's long-term development. So very important to be doing that work. We're excited because we've reached a very high level of reliability for the screening to happen. And now we really have to make sure that every child has access to that, and that the communication and the referral is appropriate. So I think my last slide is just a little discussion about specifically about how we feel primary care needs to collaborate with early childhood settings. So we recognized early on with our colleagues as part of this cross-sector group that early childhood teachers, they're with children large parts of the day, and they have valuable observations about that child's development to share. They also desire and appreciate getting communication, right? So how do we do that with schedules not being the same for somebody, for a teacher to try to get a hold of a child's primary care clinician or vice versa? It's not a simple thing. We also knew that early childhood teachers would like to have recommendations to promote kids' development, or to have suggestions about maybe a development, behavioral issues that may be difficult in the classroom. If part of Head Start, teachers also have access to infant and early childhood mental health consultation. So then again, really strengthening that ability to serve that child and serve that family. And finally, it may be that the early childhood setting is also doing screening. I know in many states, screening is happening in early childhood settings. In my state, really mostly only in Head Start, but it's very important for us to be able to collaborate and not give families conflicting messages, right? So if you got screened over here and you got screened over here and you heard the family felt like they heard something different, it's important for people to be able to communicate and assist families with that. We are currently very interested in maximizing the role of child care health consultants. I know that that is not universally available. Even within my state, there are some counties that don't have child care health consultants, but we are trying to expand support for expanding child care health consultants. I know other states also have this service as liaisons between primary care and child care to enhance and facilitate that communication. So folks who know me know that this is something, this work has obviously taken a huge part of my life in working in early childhood and trying to promote healthy development and also identify early concerns that families may have about their child's development. And I've had tremendous interest in how early childhood folks and primary care and health can do better with working together and collaborating. So I hope that this inspires some folks to see what's happening in your own state and get involved in this work as well. So I'll stop there.
Thank you so much, Dr. Earls. I had the privilege of meeting you several years ago, and it was obvious what a passion this is for you to do better and for all of us to do better with this work. So I'm so excited you could be here today. And our next speaker today is Dr. Alderman. So Dr. Alderman, I will turn it over to you.
Thank you very much. Can you hear me okay?
Yep, we can see you and hear you.
Okay. Wonderful. All right. It's a pleasure to be here today. I'm very excited to share with you the project that's going on in Oregon, the Parent Mentor Project. And I will, let's see, advance my slides here. Let's see. They're going to, okay, I have no disclosures. The name of this project is Strengthening Resilience Skills, Behaviors, and Resources Among Latinx and Migrant and Seasonal Farm Working Families, Essential for COVID-19 Recovery in Oregon. This is funded by the Association of University Centers on Disabilities in collaboration with the CDC. The overall goal of this is to provide an intervention, a project that is culturally sensitive and responsive to promoting self-efficacy, resilience, and social capital within the migrant and seasonal farm working community. I'd like to start with a quote by the executive director of the Oregon Child Development Coalition, the partner in this project, Donalda, who says that we engage with families, not just work with them. Okay. So a little bit of backdrop. Live in poverty. This is compared to 23% overall and 20 percentage points higher than whites, non-Hispanic in our state. Let's see. This is really going slowly. Okay, there we go. And of significance is that we have in Oregon 21,000 migrant children during the peak season of our agricultural session. Okay. We know that the Latinx community has been disproportionately adversely impacted by COVID. In fact, 40% of the COVID cases in Oregon are Hispanics. And this is in contrast to our population being about 13% Hispanic. And we also know that the severity of those illnesses are impactful on Hispanics, with Hispanics being 4 times more likely to be hospitalized than whites. Okay. One of our pilot counties, Washington County, shows that there are a 10-fold increase in cases among Latinx compared to whites. So this is very impactful to these communities, and our project was intended to address some of those issues. When we look at both of the pilot counties in our state for our project, we're looking at approximately 20,000 migrant and seasonal farm workers and non-workers, so community members that we used as our intervention model, a pilot. So this project is designed, again, to build individual self-efficacy, resilience, and community social capital by promotion of optimal early childhood development, with the following values embedded in that intervention, including honoring the family's culture and heritage, which, as we all know, is a component of resilience, cultivating knowledge, which is power, autonomy, and control, again, control being one of those resiliency factors, and to have control over one's life. At the same time, we also were focused on using the state leaders who made up the Act Early Oregon advisory team for this project to provide them with ample opportunity to learn about the migrant seasonal farm working community, and to begin to think about how the system can also have a practice change that would be more embracing and welcoming of this special community that is currently marginalized. So here is a graphic of the two-pronged approach. Again, on the right, addressing the system of care as we continue to build on encouraging families to engage with the system as is indicated and as they wish to support their young child's development. Also, within the community, we developed a project where we called it the Parent Mentor Project. These are our parent mentors who implemented the project in their migrant and seasonal farm working communities were themselves members of that community who self-identified as having an interest, so natural leaders, if you will, to learn about early childhood development, to learn about how to conduct family visits with their fellow community members, and to walk the family through the of downloading the Milestone Tracker app to monitor their child's development. So this is promoting developmental monitoring. It also was a way of using these natural leaders in the community to build community capacity, to reinforce those trusted community channels that these parent mentors would be heading, to provide an opportunity for access to reliable information, especially during a time where there was so much disinformation going on with COVID and the political arena. Also, to encourage them and provide them with opportunities to effectively engage in a system of care that is accessible, would be accessible and again welcoming of the families, and to promote in-home early literacy, which again is a resiliency factor. So we had then strengths, guiding principles, and challenges that very much informed the project itself. The strengths were the community itself. They're very strong community. They're very proud, and they show a tremendous amount of resilience. It's not easy to be a migrant seasonal farm worker for a variety of reasons, and they have incredible strength and resilience to do that and thrive in the community. Also, they have tremendous amount of social capital. They work together, they live together, they travel together, and they have, as a result of that, they have much social integration at the group level, at the population level, many connections there. Also social networks, that is, each individual has multiple social networks that they can rely on and lean into and be an active participant in. So there is a lot of interpersonal care, trust, and respect within this community, and which is another tremendous strength. And there is very importantly self-determination. And so we wanted to think about how we can continue to promote those and use those as a strength-based approach to the project in the parent mentors doing the family visits. The guiding principles were empowerment of the community, building self-efficacy, family engagement as one family member in the community as the parent mentor visits and engages with another family. Human rights is also a very important aspect. That recognizing that this community has basic human rights for which they are entitled. Recognizing and honoring the human dignity that everyone is entitled to. It was also a very important guiding principle. Being culturally sensitive and responsive, using a local community member, is much more achievable as they were themselves members of the community. And really did provide direction and took much ownership in the project. The parallel process and infant mental health principle also played into the design of this project. I, as one of the principal investigators in this project, was very much always just in the wings to be supportive. That the spotlight was on the parent mentors and the local county agency that engages with this community. And I supporting the local agency so that the local agency can support the parent mentors, and then the parent mentors can support the families, and the families then can support their children and their development, that parallel process. And then focusing on a common interest in that we all have, a focus on child development, which there again is an element of resilience. There are, in addition, multiple challenges. Racism, they are a marginalized group of people, poverty, trauma, historical trauma, and current trauma. COVID, as we have all been enduring, but was particularly impactful on this community. The social constructs that need to be addressed in order that these families can truly be engaged, no longer marginalized, and receive the services that they are entitled to. Financial constraints are also a part of it, and the system overall. Okay. So there were some basic public health principles that informed the model implemented, and that also strengthened the model and assured that we were doing trauma-informed approach with the community, and that all of our work was ethically and equitably implemented. The ecological model, where we have the child surrounded by the family, surrounded by the community, surrounded ultimately by policies and practices, was very much a component of this model, and through that model enhance the social context within which this project was implemented. Those connections were very important. Close-knit networks that is a characteristic of this special community. We would want to be sure that we recognize those, that we honor those, and that we don't inadvertently provide an intervention that would disrupt those. Because we do know that social supports are very important as protective factors, and this community has those social supports, and we wish to certainly never disrupt those, but actually have those be a component of the interventors implemented. We see how strengthening social networks can strengthen the community, and building the community capacity with these natural leaders in the community who are themselves community members is a way of strengthening those social networks and strengthening the community overall. And also then the intentional network building and strengthening of those social supports is a very important component of this project. The parent mentors have shared some really delightful stories about how their role in the community has played out. One parent mentor shared that she now in her apartment complex, she has had family visits with multiple families in her apartment complex. And the young children in the apartment complex now refer to her as their mother's teacher. And in fact, one parent mentor shared that after the child participated in the family visit with the parent mentor and saw their mother as having a teacher, became more excited about starting kindergarten in the fall so that she could meet her teacher as well. Okay. So again, just to underscore, reinforce, resiliency is at the individual level and the community level. At the individual level, this intervention was promoting problem-solving capacity, was providing access to trusted channels of communication, access to reliable information, so very important for a feeling of self-efficacy, and an awareness of the control capacity that families and community can have when they have these kinds of infrastructure in their community and connections to the web of care services that promote early childhood development. At the community level, resilience included empowerment of this community, competence, and confidence. And again, just to underscore that other prong of this project being that the system of care now has a deeper understanding about this special population, migrant seasonal farm working communities, their strengths, their challenges, and their eagerness to support their young child's development and to engage with that system. So that system now has an ethical responsibility to look at how and more effectively embrace with the migrant and seasonal farm working families. So in conclusion, I'll just read here. The Oregon's Parent Mentor Project promotes early identification of children with developmental delays by focusing on empowering migrant seasonal farm working families to engage in developmental monitoring or surveillance through partnering with Oregon Child Development Coalition and using their evidence-based Parent Mentor Project. So thank you very much.
Thank you so much, Dr. Alderman. What a wonderful presentation this has been today, and the webinar has just been so rich with so many resources. And what we want to do for you is we want to acknowledge that we have, oh, I skipped right over the resources slide. We do have some resources here, and we want to thank our partners at ACF and Head Start in providing these resources on this slide. And so these will be resources that you will have access to when we send you the slide deck. And we also want to thank all of our presenters for today and for their time, for the American Academy of Pediatrics for working with us on this particular event. And we do have some upcoming events. We have an August 4th, 2021 webinar, which will be Perspectives from the Field. And it will be speaking specifically to the state stories and what's happening with developmental screening. And then we do have a 2021 Community of Practice, Expanding Developmental Screening Initiatives that we will be sharing at the same time as we share that webinar on August 4th. We will also share information about how to join that community of practice. And we have captured all of your questions in the chat, and we will be sharing those out with our speakers and sending out responses so that you have that information. But we want to make sure that we get to our polls. We do have a couple of other polls that are required of us as part of our evaluation, and we really would like to hear from you. How much has your understanding or awareness improved of opportunities improved to collaborate with partners and increase access to developmental screenings for all children? And we have one more poll after this, and then we will go back to the slide that shares our contact information. And on that slide, you'll see that you can reach out to us with any questions or any concerns, questions, ideas that you had that were generated by this webinar and that you would like to share with us. And we really appreciate your participation today. Sarah, thank you for going to the next poll. How likely are you to use this information, one of the strategies to collaborate to increase access to developmental screenings? And Kathleen, you reminded me, if you would like to also add to the chat box any ideas of other things that you would like to hear more about on another webinar, we would love to hear those as well. That would be really wonderful for us to capture. So we would love to have those there. So we'll make sure that we capture that, Kathleen, and we can save that and think about that moving forward. Thank you all for your participation, and we're 3 minutes over, so it's time for us to go, but you have a great day.